Yes, спасибо большое.
Да, да,
Окей.
Лоран, здравствуйте. Здравствуйте.
Здравствуйте. Здравствуйте. Меня зовут Лоран Серве. I'm super happy to be with you today. Of course, I would like to be in Russia with you. Okay, so I'm going today to talk to you briefly about the past, the present, and the future of spinal muscular atrophy. So I indeed work today in Oxford, in the UK, in Liège, Belgium, where I still work, and I used to see several Russian patients. As you may imagine, I have a couple of disclosure. Yeah, my disclosure for this talk. So let's briefly talk about the past. It was a long journey to be where we are today, and to better appreciate what we are able to achieve today in spinal muscular atrophy, we probably have to remind what is the natural history of spinal muscular atrophy. So over the last 18 years, there's been a tremendous amount of science and then clinical trials conducted in the field of spinal muscular atrophy. And this is just, a snapshot with the most important milestones in the research, on the regulatory point of view, and on the clinical research that have been conducted for the last 18 years. We must remember that spinal muscular atrophy is actually a rare progressive neuromuscular disease. It's characterized by muscle denervation, skeletal muscular atrophy, overweakness, and loss of motor function and ambulation. And this has secondary consequences on scoliosis, repeated episodes of pneumonia, difficulties with sleep and nutrition, and need for respiratory, nutritional, orthopedic, and mobility support. All of this lead to a loss in quality of life. And we must remind that this is a progressive and neurodegenerative disorder. This is a disease with a very large spectrum. It starts with SMA type 0 that starts in utero, and when the children are born, they are already very symptomatic. And it goes up to SMA type 4 that starts in adulthood. And which is strange is that actually all these forms are due to the same mutation, which is actually mutation of a gene that is called SMN1. And how is it feasible? How is it possible that the same mutation on the same gene leads to such a broad phenotypic spectrum? It's because we have another gene that is called SMN2, which is nearly the same as SMN1, but there is a C2T mutation that affects the splicing sites of SMN2, and because of that, the protein that is read from SMN2 is, for most of the amount of protein, not functioning. And there is only a little bit of this protein that is functioning. And you can easily understand that according to the amount of SMN2 gene that you have, you may have a different phenotype. And the most severe form have 1 or 2 copies of SMN2, and in the less severe form have 4 copies. But we must keep in mind that this is a rules that help, but it's not the only one, and there are other genes that are involved. And the second thing that we must know is that this quantification of SMN2 can be very different from one to another lab, even if the labs are excellent. It's not a problem of good labs and bad labs. It's a problem of standardization between the different labs. And today, it's very frequent that a patient comes from an excellent hospital and is said to be with 3 copies of SMN2. And when you see this patient, he has actually 4 copies or 2 copies in your own site. And this might happen. So in patients with SMA, mutations or deletions in the SMN1 genes result in insufficient levels of the SMN protein. Sorry. Let's remind, yes. So let's remind that in the most severe form of SMA type 1, patients used to survive less than 1 year. And this has not changed over the last 20 years. And if we look at the patients on a motor perspective, not on a survival, but a motor perspective, this is a neurodegenerative disorder. And patients, when they are diagnosed, they do not improve. This is also true for patients with type 2 and type 3 SMA. And after the initial progress in life, when they start declining, they do decline. And this is a progressive disorder. We know it from different natural history studies. This is the one that we conducted in my center. And it's very clear that these patients over life decline. So it means that a first achievement could be to stabilize these patients. And if we could stabilize these patients, at least most of patients express that this could be an important achievement and an important milestone to know that they are out of this road that goes down every day. So what's the current management of these patients? As Olga mentioned to you, multidisciplinary care is super important. And I just want to start by emphasizing this. There is no way of treating SMA, whatever is the drug, if you do not take care of all this aspect of the disease. You cannot treat SMA alone. You need to be a team and you need to work on all these different aspects. Of course, the level of involvement of the different healthcare providers will be quite different from type 1, the most severe care cases, to type 4. And you will need a much bigger team for type 1. And now we have new treatments that are coming. We can imagine, for instance, replace SMA by bringing a new gene. And we know that this is not science fiction. It's today a reality and a drug that is approved in the US and in Europe. It's the so-called Zolgensma or onazamnogen or Bapravovec that is now available through the world. And then we can also work on SMN2. And there are different ways of working on SMN2. You can use antisense to avoid the splicing of a SMN2 or to modulate the splicing by using small molecules. And finally, you can also work downstream on the muscle by increasing the regeneration and the proliferation of the muscle using anti-myostatin or working on the muscle fibers contraction. Nevertheless, we have today 3 drugs that are approved in the United States, 2 drugs that are approved in Europe, but we still have an important unmet need. And there are still many patients today, type 1, type 2, type 3, who feels better, but remains with important need in terms of medicine, in terms of psychological, physiological support, in terms of rehabilitation. And all of this needs to societal pressures and financial burdens. One of the ways to tackle this issue is to start to treat as soon as possible. And to treat as soon as possible is probably the only way to do it is to go through newborn screening. With newborn screening, you have the opportunity to detect any patient at birth and to treat him at birth. And as I will show you tomorrow, the results are completely different, are dramatically different of the results that we can see in patients who are symptomatic. And I want to emphasize that when we advocate for newborn screening, it's not trying to put in a position, to place in a position patients who are born today and who still have a huge unmet need, and patients who are not yet born. But by avoiding that patients who are born today and tomorrow and the day after tomorrow, if we treat them after the symptoms, they will present an important burden, and they will use the resources that we can use today for patients who have been diagnosed and who are treated today. So I think that newborn screening, by decreasing the financial pressures and the need on healthcare providers, has also the potential to decrease, to improve the patients with SMA who are already born today. This is a recommendation from a working group in the US. We must be very careful. This is not evidence-based, and the same group has issued a statement that patients with 4 copies should also be treated. But this is absolutely not evidence-based. In Belgium, we have started newborn screening 2.5 years ago, and I'm quite proud to say that first thing first, we could detect 9 patients out of 105,000 newborn, and they were all successfully treated. And that this pilot project will end in the coming months and probably be transitioned as a policy at the Southern Belgium level. And I'm also happy to become incompetent for SMA, because I don't see new SMA patients in Belgium anymore, because they are detected now at birth and treated before. And that's just to maintain my skills, that I went to the UK to be still able to see symptomatic cases. I'm joking, of course, but I think that it's extremely important to understand that today we have the possibility in a country to make SMA virtually disappear. And there are patients who are born today, they will not be screened, they will live hopefully for 70, 80, 90 years. If we want to treat them as best as we can, we have to keep the resources for these patients, the resources in terms of ventilation, of pulmonary support, of rehabilitation. And if we want to keep the reserve and the resources for these patients, we have to screen the others to avoid consuming the same resources. So what's the future? The future is that the natural history is going to evolve. Rather than being a disease in which the road goes slowly down, the SMA has become a disease in which the road goes slightly up. New therapies will change the natural history of SMA. And what is likely to happen in the short term is that it could be an effective increase of number of patients because of awareness, longer life expectancy, or decrease because of carrier screening. And you know that in many countries now, there are carrier screening programs that have or that will start. So it's not yet clear what will be the consequences in the population. A spectrum of treatments will be required to address evolving needs. And of course will come the question if we have to associate this treatment and how they could act together. And this is an open question that we will discuss tomorrow. Children with type 1 SMA will likely live for longer and will achieve motor milestones normally associated with less severe types of SMA. That's fantastic to know, but we must be aware that these patients will need respiratory support for most of them, will need for rehabilitations, and that each year that we pass without screening, we will increase this population of patients in need of support. And then we will see more and more adults. We will see more and more adults who are previous type 1 or type 2. They will enter into affective life, social life, and will come new problems and new issues. And I can tell you that many of my young adult patients now ask the question, if I'm on Risdiplam, if I'm on nusinersen, if I've received gene therapy, may I have a child? And these are new issues that we'll have to tackle. And as long as the patient was being treated after the symptoms, will always be symptomatic. There will be a huge pressure for combination therapy, even if there is few evidence of efficacy of this combination therapy. And we will discuss about it tomorrow. I would like to finish this talk with this family. This is a family from Poland, and she is my older pre-symptomatic patient. And we know she has been treated very early after birth. Because she has a brother, this young gentleman who is affected. And that's the family today, 4 years after treatment. As you can see, pre-symptomatic patients may help post-symptomatic patients. Not only to play, not only to bring them in the pinky girly room, but also because the time that the parents do not spend with this little princess, they can dedicate it to this young gentleman. And I think that this is a nice allegory to finish this talk and to tell you we need as a community to continue struggling, to do our best to help patients who exist and to avoid that new patients come and consume the resources. So I thank you very much for your attention. Spasiba bolshoi. I will be happy tomorrow to discuss more in depth about the different treatments that are available and the opportunities that they offer in terms of combination. Thank you very much for your attention.
Спасибо большое, Лоран, за прекрасное выступление. Спасибо большое за то, что вы с нами были здесь сегодня.